who died with this condition. And the ones that I see have what I call unicuspid and unicommissural stenosis. I know that it's not always easy for you as clinicians to be precise in defining the phenotype of the lesion before you. So today we're going to be discussing that problem. And I'm going to be joined by DIANE Spicer, and DIANE is going to be demonstrating to you the anatomy not only of the unicuspid variant, but also the bicuspid variant. And then we're particularly pleased today that we're going to be joined by Alan MAGEE. Now you can see at the bottom of my images that I have a strong connection with Wessex unit in Southampton. And Alan is one of the pediatric cardiologists working in Southampton. I've known Alan for a very long time. So Alan is going to be discussing with you the clinical problems that confront you when you are met by an infant or a neonate with critical aortic stenosis. So it's my place now to set the scene. And what I'm going to demonstrate, and then DIANE will pick up on this, is that the essence of the lesion is the lack of the semilunar hinges of the aortic valvar leaflets. And paradoxically, I know all the time, you as echocardiographers, you talk about a valvar annulus, but it's a paradox that when we have the critically stenotic aortic valve, there truly is a ring-like attachment of those leaflets. And that's what DIANE will be showing you. She'll also emphasize to you that one of the problems that confronts you is that oftentimes there's severe ventricular hypoplasia. Indeed, it's questionable as to whether these should be considered as part of hypoplastic left heart syndrome. And in the hearts we see in the autopsy room, oftentimes there is also endocardial fibrosis, fibroelastosis, adding to the problems that confront you as clinicians. So this is how I see the valves. You're going to see a much better image of this when DIANE shows you the specimens, but what we see here is vestigial interleaflet triangles. And we as anatomists, that's what we're going to concentrate upon when we discuss this entity. Because the essence of the unicuspid and the unicommissural variety is that there is only a solitary zone of apposition in the skirt of valvar leaflet tissue, and that points back towards the mitral valve. So if I make a drawing to show you what's going on, you see there is the solitary zone of apposition within the skirt of valvar leaflet tissue, and it's pointing at the mitral valve. So we have a fused zone of apposition between the leaflets. In fact, in the unicuspid variant, as we'll show you, we have two such fused zones of apposition, and the fusion of those zones of apposition mean that the interleaflet triangle is vestigial. And that is where we get the annular paradox, because the normal arrangement, and DIANE will also be showing you the normal arrangement. In the normal arrangement, the leaflets have semilunar hinges, so they lack an annular attachment. So the paradox is that the more obvious we as morphologists see the annular attachment, the worse is the degree of valvar stenosis. Now, DIANE will also be showing you the situation when the valve has two leaflets. And she's going to emphasize that we need to distinguish in this regard between what we call leaflets and what we call sinuses. And one of the problems that confronts us these days is that people indiscriminately use the word cusp. So I hope we won't be using cusp today. We're going to try and describe leaflets and sinuses. And what DIANE will show you that in the unicuspid variant, there are two raphes. And the raphes emphasize that zone of apposition between the leaflets that is silted up. So the distinction between the unicuspid, the bicuspid variant is that in the bicuspid valve, there is only one raphe, and the valve is built on a trisinuate pattern. But what I'm also going to emphasize is that in some instances, the valve with two leaflets can also be bisinuate. So one of the things we should be discussing is the abnormal phenotypes we see in the setting of the so-called bicuspid aortic valve. And you will know that oftentimes this problem does not present in the neonatal period. Many times it's adolescents or adults you see with the bicuspid valve. And then typically those valves are bicuspid but trisinuate. And there are three specific patterns that are common: the conjoined right and left sinuses, the conjoined right and non-coronary sinuses. Those are the common variants. In fact, I misspoke a moment ago, because rarely you can have the situation in which the right coronary leaflet and the non-coronary leaflet are silted up. That is unusual. It's also unusual to have the bicuspid variant that also has only two sinuses. But a lot of that depends on how often you recognize it. But we need to distinguish all of these in the morphologic sense from the trisinuate template that has a unicuspid leaflet. And that's what DIANE's going to be showing you. And she's going to be emphasizing on the significance of the interleaflet triangles. So to emphasize again, in the unicuspid unicommissural variant, two of those triangles will be vestigial. In the bifoliate but trisinuate valve, only one of the triangles will be vestigial. Whereas if you have the bisinuate and bifoliate valve, there will only be two triangles, and you will not find a raphe, you will not find a vestigial interleaflet triangle. So let me now put this into the context of morphogenesis and try to explain to you how and why we have these different phenotypes. Because what we've been discussing in recent weeks is that the arterial roots develop in the middle of the outflow tract. And what I'm going to show you is that the leaflets remodel from the distal end of those cushions that separate the initial common lumen of that outflow tract. But the cushions don't do the whole job. There is also a proper aortopulmonary septum. This is something, again, that we've discussed before, so I'm going to show you today the significance of the cushions as opposed to the aortopulmonary septum. You know now that I'm basing my interpretations on these interactive PDFs that have been prepared by Wout Lammers and Jill Hicks-Poors. And so here is our starting point. This is when we have an outflow tract which has exclusively muscular walls, and it's extending from the margins of the right ventricle to the margins of the pericardial cavity, where it becomes the aortic sac. So if I show you that in the setting of a histologic section, and we're relatively early in development, we're just after the end of the 4th week of development, you see that the outflow tract has a proximal part, then it takes a sharp bend, the dogleg bend, meaning it also has a distal part, and then at the margins of the pericardial cavity, the cavity itself becomes embedded in the pharyngeal mesenchyme, and the aortic sac gives rise to the pharyngeal arch arteries. The key point at this stage, it has exclusively myocardial walls. But that, so at the 13th stage of the Carnegie situation, when the embryo is about 5 weeks old, the outflow tract has only proximal and distal parts. Its cavity at the margins of the outflow tract is continuous with the cavity of the aortic sac. At this early stage, the walls are exclusively myocardial. But that does not last for long, because in the next stage, so Carnegie stage 14, here we are, there's only another 2 days gone in embryonic development, and now there has been a distinct change in the distal part of the outflow tract. Those crevices that you see there mark the extent of the pericardial cavity, but now the distal part has become non-myocardial. New tissue has grown in that is non-myocardial from the heart-forming fields, specifically from the second heart field. And now there has been retreat of the myocardial border towards the base of the ventricular mass. There's also been growth of a protrusion from the dorsal wall of the aortic sac, and that also enters the distal part of the outflow tract, and so that now is a true aortopulmonary septum. But as yet, it has not fused with the cushions. There is an aortopulmonary foramen at this stage. So the outflow cushions now are spiraling through the remainder of the outflow tract that has myocardial borders. And in that part with myocardial borders, we can recognize a middle part, a proximal part. I can show you that again in a histologic section, and there very nicely now. You see the distal non-myocardial component and the aortopulmonary septum that is separating the cavity of the intrapericardial aorta from the intrapericardial pulmonary trunk. In this particular embryo, again graded at Carnegie stage 15, the aortopulmonary septum in fact has fused with the distal margin of the outflow cushions, obliterating the aortopulmonary foramen. So there are the outflow cushions, and very nicely now you can see how they are spiraling through the persisting part of the outflow tract that has myocardial walls. So that is the middle part, the proximal part. So very rapidly, non-myocardial tissues have grown into the outflow tract at the margins, producing a new distal non-myocardial component, whereas the part with myocardial walls can now be said to have middle and proximal parts. But how do we distinguish those middle and proximal parts? So I've taken you on one more stage. 2 days have passed by. Now we're in what we call Carnegie stage 16. The distal component is now separated into the intrapericardial aorta, the intrapericardial pulmonary trunk. So there is our middle part. It still has myocardial walls, but those outflow cushions have now fused in this middle part. So we can recognize this middle part because at this stage, the outflow cushions have fused in this middle part. They have not fused proximally. It has retained its myocardial walls. And the key point now, it is the remodeling of the cushions, the cardiac jelly in this middle part that will produce the arterial roots. So another cut through an embryo at the same stage. In fact, it's the same embryo. I've just rotated the cutting plane a little bit more so I can show you the developing aortic root. And there is the developing aortic root in the middle part of the outflow tract. And we can see that those major cushions have fused centrally, but the other key point that permits us to recognize this middle part of the outflow tract is that 2 new cushions have appeared. And these have been seeded by the ingrowth of the non-myocardial walls. They have seeded the cardiac jelly to produce what we call the intercalated valvar swellings. And if I take a cross-section across this middle part of the outflow tract, 1 stage later, as you see, Carnegie stage 17, we're nearly at the 7th week of development now, but hopefully you can see how we are forming these arterial roots. Because the cushions have fused centrally, but they have not fused peripherally. And now the interdigitation of these intercalated cushions with the unfused peripheral margins of the 2 major cushions are permitting us to recognize the aortic root, the pulmonary root. Note that they are still within the myocardial walls. And then if we go on one more stage, and now we're at the beginning of the 7th week of development, we can see in this oblique equivalent, oblique subcostal equivalent, the aortic root, pulmonary root, still within their myocardial walls, but now I hope you can see that the cushions are fused centrally, but those unfused components, along with the intercalated valvar swellings, are excavating to form the valvar leaflets. And it's what happens during that process of excavation that explains what gives us critically stenotic aortic valves. Because here's the same picture I showed you again, the short axis, cushions fused centrally. But if that fusion extended all the way out to the margins, then we would have the primordium of a bicuspid valve with fusion of the two coronary aortic sinuses. Whereas if there was a fusion between the right coronary sinus that is developing and that intercalated aortic valvar swelling, you would have the variant in which it was right non-coronary fusion. Whereas if the intercalated valvar swelling did not form at all, this would give you the primordium for the bisinuate and bifoliate valves. And it follows that if two of the zones of apposition silt up, then you would have the primordium for the unicuspid and unicommissural variant. So based on what we now know about anatomy and development, I think we can offer reasonable explanations as to why we get these different phenotypes. We're still working on how the valvar sinuses develop along with the interleaflet triangles, but I think we can now set the basis for understanding what DIANE is now going to show you in terms of the anatomy, and which Alan will then follow up and put the whole thing into the clinical context.
Perfect, Bob.
We're going to start by looking at the normal aortic root and its anatomic considerations. The aortic root, unlike the pulmonary root, has both muscular support and fibrous support, whereas the pulmonary root has an entire muscular junction between the fibrocollagenous wall of the pulmonary artery and the subpulmonary infundibulum. In the aortic root, the left coronary and the right coronary leaflets are typically supported by muscle, with a small crescent of muscle easily seen at the base of each of these sinuses. The mitral to aortic fibrous continuity is the fibrous support of the aortic root, and that typically extends to a portion of the left coronary leaflet and the non-coronary or non-adjacent leaflet. The membranous septum is also associated with the area between the right coronary and the non-coronary leaflets. The aortic valve has no true annulus, and the echocardiographers draw a virtual line at the base of each of these sinuses for their echocardiographic annulus. Probably the only true ring that there is within the aortic root is this area, which is called the sinutubular junction, and this is where the distal extent of the aortic root joins the tubular aorta. It is also where the leaflets attach at the distal component of the aortic root, and the interleaflet triangles extend between the leaflets to that distal extent of the aortic root, or to the sinutubular junction. The aorta is a trifoliate and trisinuate valve, so there are 3 interleaflet triangles, this one between the left and the non-coronary leaflets, this one between the left and the right coronary leaflets, and this interleaflet triangle between the right and the non-coronary leaflet, which is usually in direct association with the membranous septum. If we move on to look at bisinuate or bicuspid and unisinuate or unicuspid aortic valves, both of which are highly associated with critical aortic stenosis, which is the basis of our discussion today. This bifoliate or bicuspid aortic valve has two leaflets. And typically, one leaflet appears much larger than the other, but there are three sinuses. Here is our aorta to mitral fibrous continuity and the membranous septum. There's a well-formed interleaflet triangle between the edge of this bisected left coronary portion of the leaflet and the non-coronary leaflet, and a well-formed interleaflet triangle between the non-coronary leaflet and the right coronary leaflet, or portion of the right coronary leaflet. Tilting the valve up allows us to see within the sinuses both of these interleaflet triangles reaching to the sinutubular junction, but the interleaflet triangle that effectively partially divides the right and left coronary aortic sinuses is forming a raphe. This raphe is indicative of a poorly formed interleaflet triangle, which typically on the attachment of the valve at the distal extent of the aortic root, you can see that vestigial interleaflet triangle. There's typically a little notch there that is in direct border with that raphe. Looking at a larger heart, but on short axis from the base, this particular specimen also has a bifoliate or bicuspid aortic valve. So this non-coronary leaflet and sinus are quite large. The other sinuses, the right and the left coronary aortic sinuses, are much smaller. But there is a bifoliate valve within the sinuses between the right and left leaflets. There is an incomplete interleaflet triangle, or a raphe, this little thickened ridge dividing the left and right sinuses. This particular specimen was cut in the long axis, and looking at this portion of the divided sinus, there is that raphe and the incomplete interleaflet triangle. So it's a vestigial interleaflet triangle and fails to divide these coronary aortic sinuses in this particular specimen. Looking at a unicommissural or unicuspid aortic valve on the short axis, there's our pulmonary trunk, here's our aorta, mitral valve, and tricuspid valve. The mitral, or I should say the left atrial endocardium, is extremely thickened, and there is endocardial fibroelastosis within the atrium. The aortic valve has a keyhole orifice or a solitary zone of apposition. There is a ring-like skirt of tissue attaching at the left ventricular outflow tract in a ring-like fashion. There is one complete interleaflet triangle, which typically points towards the aorta to mitral fibrous continuity. And you can clearly see that that complete interleaflet triangle is pointing to the mitral valve. Also, there is that solitary zone of apposition, which forms sort of a keyhole orifice. Looking at this type of valve in open fashion, Here is our aorta to mitral fibrous continuity. And in this area, there is our complete interleaflet triangle reaching all the way to the sinutubular junction. The other interleaflet triangles are incomplete, giving us this unicuspid or unifolate arrangement. So there is an incomplete interleaflet triangle and the associated raphe between the non and right coronary leaflets. And there is a second raphe partially dividing the right and the left coronary leaflets. The vestigial interleaflet triangles are seen where the valve attaches to the muscle. There is one there, and the second is there. They are sometimes difficult to see, but they are represented by small little roughly triangular dimples where the valvar leaflets join at that incomplete interleaflet triangle. You can also see how this valve attaches in annular fashion within the aortic root. And it's paradoxical that the abnormal valve would give us an annular appearance, whereas the normal aortic valve has no true annulus. This heart is progressing to become hypoplastic left heart. You can already see on outward appearance that the right ventricle here is forming the apex and the left ventricle does not quite reach the apex. There's also extensive endocardial fibroelastosis within this left ventricle. The mitral valve is also stenotic with thickened tendinous cords. The last case is one that was followed in utero with critical aortic stenosis. And once the patient progressed from stenosis to an imperforate valve, the patient was emergently delivered. You can see that the left ventricle is very hypertrophied, but almost has an internal, slightly dilated appearance, and there is endocardial fibroelastosis. This valve has a solitary zone of apposition, which is just here, again pointing towards the mitral valve, and you can see that that zone of apposition reaches the sinutubular junction. Opening this valve a bit and looking down into it, there is a solitary zone of apposition here with an incomplete interleaflet triangle and a raphe dividing the non-coronary and the right coronary aortic sinuses. The valve has a roughly dome-shaped appearance. The other incomplete interleaflet triangle is just here and has been bisected, but you can see the thickened portion of the aortic root and see that it does not reach to the sinutubular junction. The opposite half of this particular specimen again shows us that thickened area, which is the raphe that's been bisected and not quite reaching to the sinutubular junction.
Okay, well, ladies and gentlemen, I'm very grateful to get the opportunity to discuss this topic, and it's very nicely been introduced by Bob and Dan in their presentations. I want to try to discuss the clinical management of neonatal aortic stenosis and what might be the influence of valve morphology. I guess my disclosure is I've performed a modest number of balloon dilatations of the aortic valve over the years, mostly in infants. So I'm coming from this originally from a catheter-based point of view. And what's the size of the problem? Aortic stenosis occurs in about 0.22 per 1,000 live births in children. And it's critical in about 10% of these. In other words, they're going to be sick neonates.
Okay, I'm ready to watch.
And the other thing to remember
Okay.
is this is lifelong disease. So individuals will go through a lot of interventions over their lifespan, and it's our interest to try to reduce this. Now, again, I want to start the story from the catheter viewpoint, and you'll see why later. This is the first balloon dilation of the aortic valve performed by Lababidi in the University of Missouri in 1982. It was an 8-year-old child, and he got a very good result. He was concerned that he might create ventricular standstill when the balloon was inflated, and for this reason, he decompressed the balloon catheter through a catheter going to the right atrium. This was not, in fact, necessary, but he got no aortic regurgitation. But this is an older child. I now want to show you some short axis pictures of the aortic valve. Again, this is an older child, and you can clearly see that there are 3 leaflets with some fusion at the commissures. And this valve, you might expect, would respond very well both to open surgical valvotomy and also to balloon dilation. Here's another valve. This is in a neonate. I'm sorry, it's slightly off axis. You can see 3 leaflets, but they aren't opening very well at all. This is a very dysplastic valve. We'll return to this one later. And thirdly, here's an example again in a neonate of a unicuspid unicommissural valve. And there is an orifice between the left and non-coronary cusps, but otherwise there must be 2 fused raphes in the other 2 zones of apposition. So what's best? Well, balloon versus catheter. This example here is one where clearly balloon is the only option. This baby weighed 1.48 kilograms. He was very sick, and we performed balloon dilation of the valve through a cut down on the carotid with a good result. But does this apply to all children? So what are we trying to achieve? First of all, we want to achieve a safe procedure, as with anything else. You want to avoid damaging other structures on the way in and out. You want to achieve effective relief of stenosis with an invasive gradient of less than 30 millimeters of mercury. Create no more than mild regurgitation, and delay valve replacement for as long as possible, because this is lifelong disease. So these are the catheter recommendations from Circulation 2012. The chair of the committee was a surgeon, interestingly, and these are the class 1 recommendations of this expert group for balloon dilation of aortic stenosis. So the first category is critical valvular aortic stenosis in the neonate, which really is the subject of this entire presentation. The neonate who is duct dependent, and it would exclude those who've got associated lesions or those with a hypoplastic left heart. That's one recommendation. The second is isolated valvular aortic stenosis when you've reduced systolic function, in which case a gradient across the valve doesn't mean anything. And thirdly, and not so much relevant to this presentation, are those children often incidentally found to have asymptomatic aortic stenosis, but have a Doppler-derived pressure drop, or a catheter-derived pressure drop of 50 millimeters of mercury. And just very briefly as an aside, there's a difference between the catheter pressure tracing and the echo, in that the catheter measures the peak-to-peak gradient, the echo measures peak instantaneous, so echo does tend to overestimate. Fortunately, however, the mean gradient in echo is pretty close to the invasive catheter gradient and can be used as a guideline. Okay, back to these 2012 AHA guidelines. In their preamble, the authors say that a relatively large literature now exists documenting the safety and effectiveness of balloon dilation for congenital aortic stenosis. I've underlined the next bit. This literature, which is 25 papers, consists primarily of single institution case series with few multi-center reports and no randomized clinical trials comparing balloon dilation with alternative therapies. Nonetheless, they go on to say the technique is widely regarded as a therapy of first choice for children with valvular aortic stenosis of sufficient severity, and that would be at all ages. I want to go back a bit to one of those 25 papers. And this was a study from Bristol in 1993, so quite early in the experience, I suppose. And it was 12 consecutive infants, all under 2 months of age, and all who were quite sick and heart failure. 4 were in Proston, 4 had severe EFE, 3 severe coarctation, and 1 significant mitral regurgitation. They all had balloon dilation of the valve. They did reasonably well, actually. The 1-month survival, 75%, and 2 early deaths were actually babies who had hypoplastic left heart, at which time there was no alternative treatment available, and the 3-year survival was 50%. Now, I want to show you the response to this paper by Professor Anderson himself. He says, in their otherwise excellent article, Bullock and her colleagues do not give any details of the morphology of the aortic valve itself, specifically the number of leaflets. This matter is of importance because the so-called unicommissural and unicuspid variant of aortic valve or stenosis, recent studies have shown the leaflet tissue is attached within the aortic root in a circular rather than a semilunar fashion, as Bob has just shown. And this arrangement would militate against successful balloon dilation. You've seen this slide already. This is a diagram of the unicuspid valve, and their normal semilunar attachment has been lost between the 2 fused zones of apposition. There is a raphe. There's a very small vestigial interleaflet triangle, meaning the valve has more of a planar rather than a scalloped appearance. And you might imagine it difficult for a balloon to successfully free the fused zone of apposition without tearing the leaflets themselves. It's also interesting the response from Bullock and colleagues. It is often difficult to be certain of leaflet morphology based solely on echocardiography in neonates with severe aortic stenosis. Now, another interesting paper around the same time was a surgical paper from Ann Arbor. Ed Beauvais was the senior author, and it was a comparison of balloon valvuloplasty and transventricular dilatation in critical aortic stenosis in the neonate. And they found equivalent results acutely, and they concluded that the treatment strategy adopted should depend on other factors, including associated cardiovascular anomalies, vascular access, preoperative condition, and the technical expertise available at each institution. And this probably is still the case today. I'd also like to say that in this group, there were only 30 neonates, 21 surgical and 9 in the balloon group, and therefore comparison is more difficult. And what they were doing at that stage was a transventricular dilatation, which in many ways is similar to balloon dilation because the surgeon could not see the valve itself. He was approaching it through an apical purse string suture using progressively larger dilators to achieve a result. But perhaps this paper here from Circulation in 2001 is the one which encouraged more and more people to use balloon dilation as opposed to surgery for critical aortic stenosis. And that's because it showed that in 110 neonates with critical aortic stenosis, the early results were equivalent. And 46% of these children were quite sick with reduced function. Interestingly, there were many more balloon dilations than surgeries in this series. However, one thing in the conclusion was that there was a greater risk of important aortic regurgitation after the balloon and of residual stenosis after surgery. However, we also know that over time, aortic regurgitation following balloon dilation tends to progress. And this is an example of a study from Geneva, I think in 2003. Group A are those children under 3 months, group B over 3 months. And not only is freedom from re-intervention worse in the smaller ones, aortic regurgitation is also worse and tends to progress in both groups. And several other people have shown this. For example, a large catheter series from Seattle, 154 children over 20 years. Half of them were neonates, and their freedom from valve replacement 15 years was only 45% in neonates as opposed to 62% in older children. And the main reason for this was aortic regurgitation. So not only is aortic regurgitation more common after balloon dilation, it tends to progress and is also the main reason why the valve has to be replaced. And these are just the figures from that study showing the worse outcomes in neonates as opposed to older children across freedom from severe AR, reintervention, and replacement. So over time, catheterizers have tried to do a better job. We're always trying to improve. Equipment has undoubtedly got better. Early on, people learned to avoid using a balloon with an inflated diameter greater than the size of the so-called annulus. They used a carotid artery approach to approach the valve in small babies because it was easier to get to cross the valve, and also attempts to improve stability of the balloon. For example, excuse me, using an antegrade approach, I wrote this paper in 1995. It sounds a lot easier than it is to achieve, and you run the risk of damaging not only one but two valves, the mitral as well as the aortic. Then there's the so-called transient cardiac standstill approach using a big dose of adenosine, and it was difficult using this technique to time the standstill with the balloon dilation. And then right ventricular pacing, which reduces cardiac output by pacing the right ventricle quickly. And this does help to improve balloon stability. However, it must be said that following balloon dilation, the outcome remains unpredictable. This is just a slide showing right ventricular pacing. I also draw your attention to the guide wire, which is the wrong position, and being posterior, it can risk damaging the mitral valve and even go through the leaflets of it. So what is the so-called annulus? What are we measuring in order to decide what size of balloon to use? For example, is it here across this valve plate? Is it here? I've thrown this further slide from Bob, and this shows what the outflow tract looks like in cross-section. Distally, you can see the stenotubular junction, then there's a ventricular arterial junction, but the valve leaflets themselves extend further into the ventricle below this, to the virtual basal ring, which we now know is not actually circular in shape. So what are we actually measuring in order to guide the balloon dilation? Not only have there been improvements in catheter technique, but there have been refinements in surgery. There's improvements in neonatal bypass and myocardial protection, and a move towards exact splitting of fused commissures and shaving obstructing nodules of the valve. And this was first presented by Mesmer et al. In 1988, a long time ago, and then the paper came out in 1991 of 28 neonates and infants below 3 months of age. They also quite often had severe aortic mitral valve disease, and they did fairly well. We know also that if you can achieve a tri-leaflet arrangement, as was shown from this paper by the Birmingham group in 2003, then the outcomes are much, much better than a bi-leaflet final result in terms of reintervention and freedom from aortic replacement. So how can we sort this out? There's an awful lot of papers, some surgical, some catheter-based out there. And how do you decide which is best, particularly in the neonate with critical disease? A randomized controlled trial will never take place. So the best we can do is either registry data or else perhaps a large single center experience of both techniques. And there are some papers which can help. This is a paper in Open Heart in 2019, again from Bristol, using the UK National Congenital Database. There were 647 patients altogether, of whom 292 were neonates. However, most were balloon dilations as opposed to surgeries. And it extended from 2000 to 2012, but only came out in 2019 because of the trouble of obtaining the data. They actually found equivalent results in terms of survival, in terms of reintervention between both techniques, not only in the whole group, but also in the neonatal group. However, the neonatal group were a little bit older, and also there were many fewer surgical valvotomies over these middle years. It is interesting looking at the trend. The trend of surgical valvotomy decreased and has since increased, and it would be interesting to see what's happened to it ever since. And this is another very interesting study. This is single center experience of St. Augustine in Germany. It's 103 patients over about 25, 26 years, so it's retrospective, obviously. This is a rather busy slide, but does show the patient groups. They're quite well matched. But the balloon BV or balloon group does have more patients with low cardiac output syndrome who have mechanical ventilation or of poor function, while on the other hand, the surgical group tends to have more patients with associated left heart malformations, particularly arch obstruction. And what they showed that clearly, while survival was equivalent between the two groups, freedom from reoperation, and bear in mind these are neonates, freedom from reoperation is much, much worse in the balloon group than in the surgical group, equivalent numbers in the same center. Freedom from replacement is also worse, although it does not tend to reach the same level of significance. And there may be several reasons for that, including patients moving from one group to the next. And lastly, what does one do with the unrepairable valve? This is a nice study from Graz in Austria discussing the Roscono procedure in neonates and infants under 3 months. This is amazing results with a very low mortality and hospital mortality of 7% out of the 44 and late mortality of 2%. However, they do seem to have no difficulty in obtaining very small homografts, which I'm sure in many places would have difficulty with. And also in the presence of a Schoen's or a small mitral valve, this Roscono procedure in neonates don't do very well. So I'm sorry about all this data and all these Kaplan-Meier graphs, but I'm trying to make some sense of this area and how does it all stack up? Firstly, a randomized trial of each treatment modality will never occur. Neonates undoubtedly have a higher rate of reintervention no matter what you do. Aortic regurgitation is more frequent after balloon dilatation and appears to be progressive and leads to earlier aortic valve replacement. If possible, achieving a trileaflet arrangement is optimal. And clearly, we talked very early on about the appearance of the valve and the difficulty in seeing it on echo. Imaging is much, much better than it was in the time of the 1993 paper, but it's still not perfect. And really only the surgeon can decide what the valve looks like when he sees it for himself. So finally, are we changing direction? In the past, nearly all children, no matter what age they were, would undergo balloon dilation as a first intervention, unless it was deemed that the valve looked totally dysplastic and hopeless for either modality. What we can say is each case must be decided on its own merits. And I believe that a clearly unicuspid or functionally bicuspid valve, for the reasons Bob has shown, is probably best to have surgery when the surgeon can separate the fused commissures and remove any extraneous tissue. And probably we're coming to a time when the main indication for a balloon aortic valvuloplasty, if you can call it that, is a neonate with poor ventricular function. And I believe that the balance is slowly swinging back towards surgery. Thanks.
Perfect. Is that okay? Yeah. Norman,
Good morning.
A lot of information here.
Yeah, almost an overload of information. Bob, I wanted to just ask you about the disparity of sizes of the leaflets in bicuspid aortic valve. For example, when the effusion is between the left and the right sinuses, the non-coronary leaflet or the non-facing leaflet is much larger. And when the fusion is between the right and the non-sinus, the left leaflet is much larger. How does this come about?
I think it's the way they develop to produce. I mean, you're talking there about the bicuspid valve, the bicuspid trisinuate valve. And I think that's, I mean, those are the ones that are typically seen in adolescence, because we know that often that you can go until a ripe old age with that valve without it becoming stenotic. And I think that's the molding that reflects the abnormality in the first instance. I think most of what we've been discussing and what Alan has been showing you in critical aortic stenosis, in fact, is the unicuspid unicommissural valve. And I think that is where you get into the real problems. And that's what I think DIANE showed most beautifully. She showed the worst end of the spectrum, which again I alluded to because of the presence of the fibroelastosis. Alan also referred to that in that study that had been done way back in Bristol from Francis Bullock, where several of their patients were subsequently considered to have hypoplastic left heart syndrome, and Alan alluded to that. So I think that the real problem in infancy and neonates is the unicuspid unicommissural valve rather than the valve with 3 sinuses and 2 leaflets.
I want to make one particular point, and that is that what we are missing in this discussion, in fact, is the development of hypoplastic left heart syndrome in the fetus, because many of the cases that are confronted with us in the fetal cardiac laboratory are patients that have the presence of a bicuspid valve or an abnormal aortic valve. And within a process of as close as 1 week, they can go from a critical aortic stenosis or even a mild aortic stenosis to the presence of hypoplastic left heart syndrome. And I think that this is certainly an area where an expert such as Dr. Wayne Turetsky from Boston or Anita Moon-Grady from UC San Francisco, who's run an international registry on this, might provide us with some treatment, some insight, because I think that the treatment of the critical aortic stenosis does definitely consider a beginning in the in utero environment. And I wonder whether DIANE has any examples of that in her collection that she might share with us or share the information. The last question that I wanted to ask before I sign off is for Alan. Beautiful presentation, Alan. Thank you for that. What is the long-term outcome? What is the unnatural history of the balloon dilatation of these aortic valves on the long term? And also from my own experience, the keyhole orifice valve is very amenable to catheterization dilatation, but it isn't that amenable to the relief of gradient. And we have some patients in our collection with critical aortic stenosis that presented following an in utero balloon dilatation, where the patient went on to develop profound endocardial fibroelastosis and died from a very hypertrophic small ventricular cavity. So I wanted to ask you, what about the success of balloon dilatation in that situation? Because leaflet thickening, I think, is a problem that isn't addressed by balloon dilatation. That's all I have to say. Thank you very much for a very interesting description, all three of you.
Thank you for your question, Norman. One of the problems is making sure we don't compare apples with oranges, because sometimes it's difficult in looking at case series to dissect out those who've got true critical neonatal aortic stenosis. And I think that certainly there's some of these patients with thickened valves and endocardial fibroelastosis. Some of them develop intractable pulmonary hypertension. And that's a very bad group, and they've missed the boat of a univentricular type of approach. I think in the long term, certainly these patients, often they can also have Shones and so forth, which makes mixing is even more difficult. These patients, first of all, have a higher mortality. I think that they do have a higher rate of intervention, and I think they have earlier valve replacement. But I don't know what happens to them going on into adolescence and adult life, to be honest with you. I mean, it's a nasty group. I think that if the function is preserved, then surgery is probably the best thing for them, because I worry about patients who have an attempted balloon as in critical neonatal aortic stenosis, and then you're faced with a rescue Ross operation, because they do very badly. You know, it's just a matter of trying to decide the best for each patient, because they're all a little bit different.
Can I make a comment there also? Because I think Alan is right when he makes the point that you shouldn't be comparing apples with oranges. If you recall, in one of his slides, one of his earliest slides, when he presented the data from circulation, the recommendation, one of the exclusions was hyperplastic left heart syndrome. And Diane made the point that some of the specimens that she showed you, I think I'm correct, Diane, those were diagnosed, were they not, as hyperplastic left heart syndrome?
Yeah, the one with the unicuspid unicommensural valve was considered hypoplastic left heart.
So I think to a certain extent, we're skewing the discussion if we talk about the fetal end of things, because I think the cases that Alan sees, correct me if I'm wrong, Alan, but they are cases that are presenting in the neonatal period and not, I mean, in the United Kingdom, we don't have much experience with fetal intervention, do we?
That's a very good point. There is not much experience fetal intervention. There was some fetal interventions performed at Charlotte's Hospital when Helena was at the Brompton, but there hasn't been a huge number. Currently, they're trying to start a prospective registry based in Sweden across Europe to look at fetal intervention for aortic stenosis, but I think it'll be difficult for them to draw clear conclusions from that. Be interested to see what happens. But there is not much UK experience whatsoever.
And despite that, Alan, we still get a significant number of patients who present to pediatric cardiologists such as yourself in the neonatal period who haven't had fetal intervention or anything, and they are the ones really that you've been discussing, are they not, who have what critical aortic stenosis has seen for the first time in the neonatal or infant period.
If it could be modified prenatally, that would be fantastic. Natural history would be great. We don't see those post neonatal fetal intervention at all. We don't.
Well, the point, of course, is that I think that there is a spectrum between critical aortic stenosis and hyperplastic left heart syndrome. It's just a question of when it begins. And that's really the problem that we get faced with. But anyway, there are a number of unanswered questions in the long-term management. Are any patients in your unit, Alan, being referred for surgical intervention, or is this now standard to do balloon valvuloplasty as an initial procedure?
I think that it tends to swing to and fro. I know that in Birmingham and at Great Ormond Street, they're now moving more towards surgery. Well, actually, Birmingham for a long time has been surgery. And recently in Southampton, there have been some patients who have had surgery as a first intervention and done very well. So I think we've got to keep an open mind and think in terms of the patient, not what we want to do. Again, it's the rarity of and the heterogeneity of the condition, but I feel that if a surgeon can actually see what he's doing, exactly what needs to be approached, it's probably better. Probably better.
Diane, in following balloon valvuloplasties, have you any autopsies of post-valvuloplasty hearts? Because the real issue about the aortic insufficiency, is this related to a relief of the fusion between the commissures of the leaflets? And are the leaflets actually ruptured in some way in a balloon procedure along the weakest point of the point of stress from the balloon?
I have seen a couple aortic valves, but more pulmonary valves. And in the pulmonary valves, they typically are torn at those thickened commissures, and the same with the aortic valve.
That's great.
I think
So I have one other important point in terms of surgical management of critical aortic stenosis, and that is that, we've seen this a number of times in our own practice, is the EFE, the endocardial fibroelastosis, can be reasonably well attacked by the surgeons. And when you take care of the diastolic dysfunction related to the endocardial fibroelastosis, the ventricular function improves, and a master surgeon can easily find a cleavage point between the endocardial fibroelastosis and the residual muscle, because it's usually endocardial. And if you get into that plane, you can dissect out the entire endocardium except for on the papillary muscles, and you can do it piecemeal as well. And then you have a ventricle which is A, bigger, and B, has no restriction of the endocardial fibroelastosis to filling and emptying. So we've had a number of patients, including UC and Stanford, where I've worked. And also this has been popularized by Pedro Del Nido in Boston. So I think that there are other options, and maybe Sasha could talk to us about his experience with this.
But there, Norman, again, you're talking about hypoplastic left heart syndrome rather than critical aortic stenosis.
No, Bob, I think that one of the interesting issues, and I think DIANE showed that very clearly, is that you can get endocardial fibroelastosis in aortic stenosis.
Oh, indeed, I'm not questioning that, but I think that again, that would tilt the balance towards calling it hypoplastic left heart syndrome rather than...
May well be the case, but I mean, the thing is that I see as a clinician is that there's a spectrum between these conditions.
Nobody's doubting the fact that there is a spectrum.
Okay.
But you've got to, if you have a spectrum, you have to divide it somewhere. And to me, one of the things that swings the balance towards either critical aortic stenosis or hypoplastic left heart syndrome would be the presence of severe fibroelastosis. That would tilt me very much towards calling it hypoplastic left heart syndrome.
I think that, Bob, is today we are again taking a point, and we saw this disease from three fantastic point of view and three amazing presentation. As a surgeon, I want to say something that we have experienced also in our center, that as I understand very well the position of the interventional, but I think that the surgical approach for the severe aortic stenosis is something that the surgeon can manage under direct view, rather than a blind dilatation. I saw Adrian that is fantastic as usual, and he suggests a gentle dilatation, because the rule of gentle dilatation is worldwide accepted. But that sometimes, as DIANE said, that the aortic valve is not the pulmonary valve, it's an high pressure valve. So it suffers sometimes very small changes in shape or rupture of some commissure that is typical and is normal for the valvuloplasty. So I'm not against nothing, but I can say that in our experience, surgical approach can be more meticulous, can be more fine when they need to open some commissure or be perfect, trying to be perfect with the opening of the valve, rather than to go fast to the theater with severe insufficiency. And what I suggest for a very symptomatic patient is to add a Ruskin procedure to decompress the left ventricle. And again, in our experience, it works a lot. So taking time and trying to keep the time, touch patient only if neonates, only if there is big symptoms. Don't touch patient stable. But if you want to try to have a stability, also Raskin procedure for very severe case can help in prolonging the time.
Sasha, I think that a Raskin procedure is not the great procedure for these patients because the atrial septum in this condition, unlike in transposition, is a very thick structure, and that what you have to do is a static balloon. I'm sure Alan would agree with us about this point. You can't do a Raskin procedure in these patients because the weakest point is going to be the pulmonary veins, and we've actually had that experience of trying to do a balloon atrial septostomy of the Raskin variety in this condition. No, this is an interventional condition that has to be handled by the interventionalist. Alan?
Difficult because the left atrium is soft and small, and it is a tricky thing to do. It tends to be quite a high defect as well, and technically to do this.
I wonder whether you would allow me to share an image with you, if I can try this, just as an interesting historical fact. This is a patient that was actually reported successfully as a surgical option in the neonate. It was a patient from our own institution. The surgery was done in the 80s by Dr. Paul Ebert. The child lived and became an equestrian expert, and unfortunately was thrown from her horse at the age of about 10 years of age. And the horse hoof caught her on the head. She had a terrible cerebral hemorrhage and died, and we had the heart for evaluation after her passing. And here you can see where Dr. Ebert did the commissurotomy between the right coronary and the left coronary cusp. But I wanted to point out also the fibrosis that occurs here. And what we're seeing here is a sort of endocardial fibroelastosis of this heart. But what we can't see, we can also see some ischemia running through the heart with the fibrous tissue extending really quite far into the myocardium here. And what we haven't addressed in the long-term history of aortic stenosis is this issue of myocardial damage, which is there. And so I wanted to show you this as an example of somebody who was living a normal life, who probably had a fairly substantial amount of aortic insufficiency, thick rolled leaflets, and evidence of fibrosis as a 10-year-old, which would probably herald further problems during life that we have not discussed with this condition.
But in that heart, Norman, there's not so much fibroelastosis as fibrosis on the surface. I mean, the papillary muscles are not involved, are a little fibrotic.
Sure.
The mitral valve looks pretty good. There's no effect on the tendinous cords or anything. Surely that's,
No.
And there's a degree of left ventricular hypertrophy, is there not?
There is, obviously.
And
a dilated ventricle from the aortic insufficiency.
But it looks more like fibrosis rather than fibroelastosis. You can't see that pearly lining like you saw in DIANE's specimens.
Sure, I agree, but there certainly is thickening of the endocardium. I mean, you don't see any fine crisscrossing apical trabeculations. They've been obliterated.
Indeed.
Fascinating to see, sorry to interrupt you, looking at late gadolinium enhancement on MRI in these hearts, because look at scarring of the myocardium. I'm not sure if anyone's done that.
Sure. I mean, I think that echocardiography is particularly weak at recognizing endocardial fibroelastosis, and certainly that is part of any clinical workup when you have to evaluate what happens and also to direct a potential surgical treatment. Because if you've got a thick peel, you're compromising the patient by just attending to the balloon of the valve and leaving a damaged ventricle to function for life with all of the attendant problems from pulmonary hypertension.
So there is a few questions, probably more for Alan. Of course, they ask you of what is the ideal timing for aortic stenosis repair.
There's also, Sasha, there's a very good question from Paolo in Porto Alegre, who says, would it be reasonable to raise the question that when there is a solitary zone of apposition with incomplete triangles, in utero dilation would be very much more difficult, if not virtually impossible? And I agree with him 100% there, because I think that DIANE's demonstration was quite beautiful. To me, the raphes are particularly thick. I think, if anything, the raphe is stronger. And I don't think there's any chance of splitting the leaflet along that raphe again, which is, to me, why I don't think what Alan said, I think that balloon dilation for the unicuspid unicommissural valve, expecting it to split it along where initially those zones of apposition were, as Paolo says, is virtually impossible. And
yet, if you look at the descriptions of balloon valvuloplasty from Dr. Turetsky and Anita Moon-Grady, you'll find that transient aortic insufficiency is very common, but it tends to disappear.
But have they, I mean, we don't know, Norman, whether those valves were going to be unicuspid, unicommissural. They might have been going towards being bicuspid valves. Have they looked at these in terms, and have they categorized them on the number of interleaflet triangles?
Petasis now, so catheterization is not an issue.
But the question was, have they categorized them in terms of the phenotypes of the valves?
Well, I can't answer that question, but I would suspect no.
So, and that brings us back to what we started from. And until we start what Alan says, until we start comparing apples with apples and oranges with oranges, and the point that Sasha makes, the surgeon is much more able to make these distinctions.
I think that's true. So, Alan, if you had a baby that you were confronted with a critical aortic stenosis, what would be your suggested approach? Would it be to go to balloon valvuloplasty as the recommendations have suggested, or would you consider surgery?
Well, critical means someone who needs something done quickly, probably also have a duct-dependent systemic circulation. I think it depends on the function. I think if somebody is very sick, acidotic, then a gentle balloon followed by surgery when things improve. Otherwise, if the child is well, surgery.
I agree. Thank you.
I agree.
Yeah.
Okay, Bob, do you have something to say or want to add something?
I think, to me, what was most beautiful today were those images that DIANE showed. I think that's the most beautiful imaging I've ever seen of the raphes and the unicommissural unicuspid valve. And I think what we now need to work towards is seeing how well, what Alan said, imaging is getting better. I think there's no question about that. I think Alan gave us a superb summary of what's been happening over a period of 30 plus years in the understanding of this lesion. And I still don't, I think that the point when Alan gave his presentation, I was listening to it when Sasha was recording it. And when he showed that letter to the Bullock paper that I'd written way back in the 1990s, I'd forgotten all about that. But I still think that is true. I still do not think that we are getting the sophistication we need in demonstrating the phenotypes of these hearts. And I think what DIANE showed us today illustrated to me what we need to be looking at and the distinctions we need to be making.
Sure, I think as you say, and I would enforce your feelings here, Bob, is that what today's presentation showed us that it's not important to just simply look at the leaflets of the valve, which we've been doing echocardiographically and angiographically, but to see if we can identify the interleaflet triangles. That seems to be the fundamental. And that, of course, creates the question of how do we do this? Because it may be possible with 3D echo to do something like this, or with magnetic resonance or CT angiography. But I don't think that with the current techniques of conventional echocardiographic imaging, that we can tell this. We can tell whether a valve has fusion between the leaflets. We can tell whether it's sinus, trisinusal, bisinusal, or whatever, but we cannot see these interleaflet triangles by conventional imaging. And so we have a little bit of an impasse here, and we have to wait for this philosophy to permeate through the medical community so that we can potentially have the opportunity of looking at the interleaflet triangles. And that is morphologically a problem. It's not a problem if you do surgery on these patients, but it's certainly a problem of imaging, I would suspect.
Can I make a suggestion that, or can I ask you, is it not feasible to distinguish the keyhole versus the zone of apposition going all the way across the root?
I think you can see that in a number of patients. The unicommissural valve, or the so-called unicommissural keyhole valve, is, I think, quite easy to identify. I have examples of that in my own collection of these features, including with morphological confirmation after birth of this, and with the patients unfortunately having died from this very critical form of aortic stenosis. So I think we can see that, but I don't think we can see the other issues that DIANE showed.
I think
by
if we
means of ultrasound.
distinguish the unicuspid formation in a trisinuate root from the bicuspid situation in a trisinuate root, that would be starters.
Yeah. Well, Bob, I think this is one of the things why I've stuck with you for, God knows, 40 years or so, is because what you have suggested is the way in which we can expand the way we think about these things in an imaging fashion. And certainly we can take some of these fundamentals that Diane has showed so beautifully and now try and apply them in a prospective manner to imaging to see whether we can look at that, because I think what we have as images on this basis here is the fact that we've radically changed the way we think about aortic stenosis from this presentation.
One hopes that is the case. I think that's what we're trying to do with the Congenital Heart Academy, isn't it? I mean, it's
Yes.
it's fantastic that we have the opportunity to discuss this with such a large audience.
Absolutely.
Okay. So Bob, you want to introduce the next week meeting? We will.
So next week we're going to return. We're going to have a very interesting discussion next week. I'm going to be joined by Saurabh Gupta, and we're going to be talking about totally anomalous systemic venous connection, which I am sure that very few of those listening today will have seen. Hopefully at the end of next week, we will get a better understanding of it, because we're going to emphasize the importance of starting off with the recognition of atrial arrangement. So hopefully we'll have a good audience with us next week. I'd like to thank Alan in particular, who I think did a great job in joining us today. I think that, to me, the combination with the clinical presentation and with the demonstration of the anatomy is the way forward.
Thank you.
Bashir, do you have anything else to say?
We are very happy, as you know, when we ask the country, we remain with open eyes, because again, we reach Saudi Arabia, Dubai, Brazil. So we are very happy, Bob. This is the philosophy, the spirit of the Academy. And this is thanks to you, because you are spending a lot of your time, a lot of your interest to help in this educational program.
And
So-
also thanks to Diane, because I think that now that we have the ability to see the hearts in real time, I mean, that makes so much of a difference. And we have, and you saw how tiny those hearts were and how she was able to get the camera right in there and show us those details. And I think this is the way forward. When we can bring the real anatomy to the attention of everybody, it's very promising.
Yes, I'm very happy because now Alan is looking to the people where he's connected and
All over the world.
all over the world. This is fantastic. So thank you, Diane. Norman, we'll see you soon. Bob,
hope so.
thanks a lot. And Alan, thanks a lot. It was a real pleasure collaborate with you.
Thank
So
you.
see
Thank
you
you
next
very much,
Friday.
everybody. Great job.
Thank you.
Wonderful. Bye.
Bye.
Bye-bye. Bye-bye.